Hello, my name is Dr. Kian Samimi. I'm a board-certified plastic surgeon, and I would like to talk to you about breast reconstruction. Breast reconstruction is a common procedure after breast cancer and after mastectomy. When it comes to breast reconstruction, there are a number of different options. The first option relates to the timing of reconstruction. Reconstruction can either be done at the time of the mastectomy or in a delayed fashion several months later after recovering from the actual mastectomy. Your breast surgeon will often decide whether you are a good candidate for an immediate reconstruction or delayed reconstruction and refer you depending on that, but also part of our consultation is to determine which is the best choice for you. The results between an immediate and delayed breast reconstruction are actually very similar. Most women who have a delayed reconstruction, or more women who have a delayed reconstruction, are actually more satisfied with their results. I believe it has to do with the fact that you see what it looks like after the mastectomy and then appreciate the result of the reconstruction more afterwards. The benefit of an immediate reconstruction, though, is that it saves one surgery and you're basically already on the way to reconstruction by the time you wake up from your mastectomy. The next choice is the type of reconstruction to be performed. There are many different options in reconstruction, but the two big groups involve either using your own tissues for reconstruction or using expanders and implants for reconstruction. The most commonly performed reconstructions are using expanders and then implants for reconstruction. Implants. Basically, depending on whether it's an immediate or delayed reconstruction, the expander is either inserted at the time of the mastectomy or later by going through the same incisions again. I generally use the same incisions that the breast surgeon has used for the mastectomy, and we discuss that prior to surgery and decide what is best for you and would be appropriate. The incisions may be just an incision across the breast, it may be kind of an anchor incision, maybe an incision around the nipple or in the crease of the breast. There's many different options, but I go through the same incision that was used for the mastectomy, and if it's an immediate reconstruction, obviously I do it at the time of the mastectomy. Now, the tissue expander does have to go under the muscle. The breast tissue is above the muscle, so I have to lift the muscle to place the expander under the muscle. That is where most of the discomfort comes from in a breast reconstruction. So I will then go under the muscle, and this is a sample of a tissue expander. A tissue expander is basically an implant that has a port in the front that allows us to add fluid afterwards by inserting a needle through the skin into this port and filling the tissue expander. So the tissue expander is placed under the muscle at the time of the mastectomy. The tissue expander should be covered entirely by muscle. It should not be sitting underneath the skin because that will not yield a good result. If the muscle is not wide enough to cover the expander altogether, I sometimes use what's called an acellular dermal graft, which is basically cadaver skin which has been specially treated for this purpose, does not have any more cellular elements, and has no risk of infection, of transmission of disease or rejection. The graft is implanted on the inside, so it's not visible on the outside, to provide coverage for the tissue expander. I then close the incisions. Typically, there is a drain also used, and I also typically use what's called a pain pump, which is a canister filled with local anesthesia, and two little wires that enter into each breast through the skin, and for about 3 to 4 days after the mastectomy, continue to infuse local anesthesia to minimize the pain. Now, once the tissue expander is placed and all the incisions are healed, we start the process of tissue expansion about 3 to 4 weeks after placement of the tissue expander. Basically, You come to our office every other week. You can come as often as once a week. It depends really on your schedule. Or if you don't have time to come to the office or other things going on, we can also do it less frequent intervals. We use a special magnet to locate the port through the skin, and then we insert a needle through the skin into this port to add fluid to it. I typically will do the first expansion myself, but my nurse will often do the subsequent expansions. The tissue expander is then filled each time with salt water, with saline, and we place as much as you can tolerate with each visit. So we try to avoid it being uncomfortable. Saying that, as the expander is stretched more and the skin and muscle is stretched, there may be some discomfort, mostly at the end of the tissue expansion. It also depends on how rapidly we expand. The benefit of this is that you have a say in the ultimate size, as you can watch and see how the breast increases in size, and then determine how far you wish to go on tissue expansion. Once we reach the size that you're comfortable with, we basically wait. I wait for about 6 months from the date of surgery, from the date of the mastectomy, until I come back and replace the tissue expander with an implant. That procedure is an outpatient procedure and is relatively easy, relatively. Every surgery has obviously its own issues, but I go through the existing incision, I take out the tissue expander, and then I replace the tissue expander with an implant. When it comes to the implants, there are many, many different choices we have available right now. Most women who undergo breast reconstruction choose to have a silicone implant placed. The silicone implant feels more natural than the saline implant and also seems to last longer. The safety of the silicone implant should be the same as a saline implant, and it yields much better results, so most women choose to go with silicone implants. When it comes to silicone implants, there are many different shapes and sizes, but basically the two groups we have are either a round implant, which is shown here, which gives more fullness in the upper pole of the breast, or now we also have the shaped implants available that have a natural teardrop shape, mimicking a more natural breast appearance. I do believe that these give the most natural and realistic result. The shaped implants typically are what we call textured. They have a roughened surface to prevent them from rotating, while the smooth implants can either come in the round implants can either come in a smooth or textured surface. Which one will be best for you, we can determine at the time of the consult. You usually don't even have to decide that in the initial consult, as we first have to go through placement of the tissue expander. Now, there's a few things to keep in mind with implants. They don't last forever. They have to be replaced every 15 to 20 years. And since they're foreign bodies, there are risks associated with placement of these implants. The most common risks are really infection, which may require removal of the implant, or capsular contracture, which means a scar formation around the implant, which can lead to hardening of the implant. There are some other complications which I can discuss with you during the consultation. The final step would be reconstruction of the nipple and areola, depending on whether these were able to be preserved or had to be removed at the time of the mastectomy. And there are many different techniques, ranging from a simple tattoo to me harvesting skin grafts and rebuilding the nipple. That is typically done as a last step 3 or 4 months after placement of the implants. Now, there are different options, and I'm going to just briefly mention some of them. Some women may be candidates to go straight to implant, meaning we do not place the tissue expander but go straight to implant. This is appropriate for a woman who wishes to be smaller than her present size and may have enough skin so I don't have to go through the process of tissue expansion. Typically, what it means is that I have to use the grafts that I have mentioned earlier, the acellular dermal grafts, and use these to extend the muscle to entirely cover the implant with muscle or graft. The straight to implant saves one step, but it is harder to achieve a predictable result because the implants may shift or move in the period after placement, and sometimes we still have to go back to revise the result. There are certain instances where there is definitely a benefit to going straight to implant, and that's something we can discuss at our consultation. Now, the next big group of reconstruction or options of reconstruction is using your own tissue for reconstruction. Using your own tissue reconstruction is a more involved process with significantly longer recovery and incisions in other parts of your body. I perform what is called a latissimus flap, which is taking muscle and skin from your back. I still have to use a tissue expander or implant or both, as there is never enough, or most of the time there is not enough skin and tissue in the back to adequately reconstruct the breast. Typically, I perform this latissimus flap after radiation, where tissue expansion by itself be too risky. I personally do not perform free flap reconstruction where we take tissue from another part of your body. And if this is an option that you would like to explore, I would have to refer you to a surgeon that performs this procedure. The process of tissue expansion is a very involved process. You have to make sure that you wish to undergo these procedures, the recovery, and the potential risks. It is not the same process as placing a breast implant, such as in a breast augmentation. A breast augmentation is a very straightforward process where we place an implant, and that usually is all that has to be done. Breast reconstruction is much more involved. Also, the results of breast reconstruction are very different than the results of breast augmentation. In a breast augmentation, you still have all of your own breast tissue, and the implant just adds fullness to the breast. In a breast reconstruction, the implant has to recreate almost the entire breast. So the breast never will feel as soft, the breast will never look as natural as it does after a breast augmentation. Also, there are a lot of reasons not to proceed with a breast reconstruction. These are things that we will discuss in our consultation. Although age by itself is not a limitation or a reason not to proceed with reconstruction, there definitely is a longer recovery and more risk of complications as your age goes up. This is something we have to decide whether it is safe to proceed. The other is underlying medical problems. Conditions such as diabetes, high blood pressure, autoimmune diseases, a variety of medical conditions can significantly increase the risk of complications with a breast reconstruction. And again, that is part of a consultation to determine whether this is a safe procedure for you and whether you should proceed. The final one that affects the outcome of reconstruction is being overweight. If you're overweight, the results will not be as good. The first problem we run into is that there may not be implants large enough to adequately or build a breast of adequate size for you to match the rest of your body frame. The other risk, or the other consideration when you're overweight, is that it significantly increases the risk of complications such as implant infection. So you have to be honest to yourself and know the limitations of what breast reconstruction can achieve. Women who undergo breast reconstruction generally are happy with their results, but it is a very, very long and involved process, and the purpose of our consultation is to determine whether you are willing to undergo this process. I'm looking forward to meeting you soon.